Good evening to one and all. Wishing you all a happy Navaratri on behalf of API, ICP and World Medical Academy. I heartily welcome one and all for this virtual update on cardiology on World Heart Day. I welcome all delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome our guest of honor, Dr. P.S. Shankar, Professor Emeritus RGHS Bangalore and Senior CEO, KBN Institute of Medical Science, Gulbarga. I welcome Dr. Maya, Patron, Dr. K. Govind Babu, Chairman API, Dr. Vishwanath, Secretary, Dr. Ravi Kirti, Central API Member, and Dr. Rajshekar, Immediate Past Chairman API, and Dr. Jayant Antani, our own faculty from Pune who has joined. I welcome our guest of honor, Dr. Muruganathan, Past President API, who will be joining shortly, and Past Governor ACP India Chapter, who needs no introduction. I welcome our today's chief guest, Dr. Alka Deshpande Madam, Dean ICP India, Padma Shri awardee, great academician, teacher par excellence with many awards and publications, a great name in the physician family in the country. I also welcome our today's speaker, Dr. M.S. Hiremed, Senior Interventional Cardiologist and Director of Cath Lab, Ruby Hall Clinic, Pune. The past President of CSI, past Convener, National Interventional Council, conducted regular live angiography courses, peripheral angioplasty courses, participated in many groundbreaking trials with many publications, both national and international, to his credit, received many awards and honors. I also welcome our own faculty, Dr. P.C. Manoria, Senior Cardiologist from Bhopal, past President of CSI and API, a great teacher of teachers with high academics, with innumerable publications, a great name in the field of cardiology in the country and abroad. I also welcome our panelist, Professor Dr. Nagaraj Desai, cardiologist from Bangalore, who was instrumental in establishing cardiology department in Ramaya Medical College and also in JSS University, Mysore, a great teacher. I also welcome our other panelist, Dr. Vivek Javdi, Chief Cardiothoracic Surgeon from Bangalore Fortis Hospitals, internationally renowned surgeon, a dynamic personality, recognized globally for his excellent work and surgical skills, and trained many surgeons under him with great academics and research, received many awards and honors, doing many innovative works like robotics and minimal invasive surgeries in the field of cardiothoracic surgery. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating the fourth wave. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize the time by hearing and exchange of knowledge with them in their respective specialty. As many delegates who have registered from many states, making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
We are virtually honoring all our guest faculty for their tremendous contribution to their work done in the respective field in the country. We are playing a short video of World Heart Day theme, the theme being use heart for every heart. Now I request Dr. P.S. Shankar sir to address the gathering.
Professor Deshpande, Professor Manoria, Dr. Maya, Dr. Govind Babu, Muruganathan, Dr. Hiramat, Nagaraj Desai, Dr. Vivek, Ravi Kirti, Dr. Rajshekar, and Dr. Sangram, and colleagues. We have assembled here to celebrate the World Heart Day, and I welcome Padma Shri Alka Deshpande amidst us, on whom I wrote an article recently in the book on Leading Doctors of India. My good friend, Dr. Manoria, with whom I have contact for 4 decades, is conducting this discussion. My distinguished students, Dr. Nagaraj and Vivek, are here, and the Karnataka domicile, Dr. Muruganathan, is there to bless this program. And I welcome all my friends from Bangalore and Pune. And this is the first time the online program is being organized, and on which, following by Dr. Govind Babu, he took over the reins of the Karnataka API from Dr. Rajshekar, though Babu is in Dhaka and Bangladesh, and I welcome all of them. Beating the heart, cardiovascular disease is something that matters to every beating heart. World Heart Day, which is celebrated every year on 29 September, was created by the World Heart Federation. It is aimed at informing people around the world about the cardiovascular diseases. And it is a global campaign through which the Federation unites the people to fight the cardiovascular burden as well as inspires and drives the international action to encourage heart healthy living. And the main aim of celebrating this day is to raise awareness about the cardiovascular diseases, its prevention, and the impact it on the people across the world. The theme for World Heart Day 2022 is the use heart for every heart. Cardiovascular disease are the most common cause of the death globally. An estimated 18 million people die from cardiovascular diseases every year. Coronary heart disease or strokes form the major cause of these deaths. A common misconception about the cardiovascular disease is that it impacts more people in developed countries who are more reliant on technology and sedentary lifestyles. But more than 80% of deaths occur in the middle income and low income countries. There are many risk factors for the heart diseases like age, sex, tobacco use, physical inactivity, non-alcoholic fatty liver disease, excessive alcohol consumption, unhealthy diet, obesity, genetic predisposition, and the family history of the cardiovascular diseases. Raised blood pressure, blood sugar, raised blood cholesterol, undiagnosed celiac disease, psychosocial factors, poverty, low educational status, air pollution, and poor sleep. Economic systems of the countries are being impacted by the cardiovascular disease. The cost of treatment is high, and the failure to treat the diseases timely results in the loss of productivity and the long absences from the work. And this situation is very serious, as about 80% of all cases of cardiovascular diseases are reported in developing countries. For this, prevention is the best cure, and we can achieve it by adopting healthy lifestyle and the diet. Hence, this day is observed with an aim to encourage all of the people to adopt a better and healthy lifestyle in order to reduce the risk of getting infected with the cardiovascular diseases for a long and healthy life. It also tries to erase all of the misconceptions regarding the cardiovascular diseases among the people and provide them with only right information. We have assembled here to listen the development in the field of heart diseases from the experts, and I am happy to associate with this program organized by Dr. Sangram, and I wish the deliberations all success. Thank you.
Thank you, sir, for your kind words of wisdom. Now I request our chief guest, Dr. Alka Deshpande, Madam, Dean ICP India, to address for the inaugural address. Over to you, madam.
Professor Biradar and his organizing team, all the stalwarts in the field of medicine and cardiology, and dear delegates. Good evening to you all. At the outset, let me congratulate Professor Biradar and his team for organizing a cardiology update on the World Heart Day. Up till now, I was only conversant with a romantic Bollywood term, Dil Se Dil Tak. There is also a Marathi song, Yaar Hridayi Se Pyar Hridayi, with a spiritual connotations to it. But today, officially, World Heart Federation has adopted the theme, use heart for every heart. I will not go into the statistics which Dr. Shankar has already given. Cardiovascular deaths top the list in the non-communicable diseases. There are a lot of risk factors which can prevent and delay the onset of cardiovascular diseases. With today's cardiology update, we will get advanced information, we'll know about advanced technology and many other factors, but they should not be restricted only to ourselves, the people in medical field. They must reach the community. And therefore, I would appeal to all the consultants, if they can spend 3 more minutes in their consultation time with the patient and the patient's relatives in a heart-to-heart dialogue and counseling for prevention of heart diseases. If there is a time constraint, we all can train one of our paramedical workers in counseling, and we can do a group counseling for people who are attending our clinics. And we can tell them the preventive measures about the risk factors or other non-communicable diseases which we can control very effectively with the present drugs in our armamentarium. And therefore, what is necessary is our dialogue, our counseling to the patients and patients' relatives. Even if we do that much, I think we will achieve a great thing in reducing the cardiovascular diseases in our country. With these few words, now we are going to get all the knowledge from our experts, so I will not go into those details. And without wasting any time, I would once again congratulate Professor Biradar and his team for this wonderful cardiology update. Thank you very much, sir.
Thank you, madam. Thank you for sparing your valuable time to join this program. Since Dr. Muruganathan is busy in his Tamil Nadu Medical Council, he has conveyed his best wishes and all the best for the program. And our chairman API, Dr. K. Govind Babu, is in Dhaka attending a meeting. He has also conveyed the best wishes for the meeting. Now we move on to the scientific session. I request Dr. Sirish Hiremat to deliver his talk. As already the guest faculty has been introduced, request Professor Manoria to take over for the further proceedings. Over to you, Dr. Manoria, sir.
The last couple of years has witnessed spectacular advances in the field of coronary artery disease, both in terms of enhanced understanding and in the availability of a panoply of newer therapeutic options. The pharmacological arm has reached great strides. The LDL cholesterol, which is causally related to atherosclerosis, can be cut to any size at the present state of time, even up to 10 or 20, with great safety, and this has great impact on reduction of cardiovascular events, particularly in the high-risk patients. I'm sure Dr. Hiremat will talk in detail about this aspect. In the antiplatelet arm, we have the new concept of antiplatelet de-escalation, which minimizes bleeding without any change in the ischemic events. And for patients with polyvascular disease, that is CAD with PAD or stroke, we have the new therapy of dual pathway inhibitor to decrease the cardiovascular events. In the PCI arm, we have better stent designs which promote healing, better implantation techniques, and if necessary, optimization can be done by imaging by IVUS or OCT. And for calcific lesions, besides ROTA, we also have intravascular lithotripsy. And the surgical arm has also witnessed great refinements and has produced excellent results with minimally invasive surgery, robotic-assisted surgery, and awake surgery, which is peculiar to our friend Dr. Jolly, which we'll discuss. So with these initial remarks, I will request Dr. Hiremat to deliver his talk. Dr. Hiremat, please.
Yeah, since Dr. Muruganathan has joined, kindly a few words from Dr. Muruganathan, sir.
Yeah, thank you, Sangram. I'm sorry, I'm in Chennai. The World Heart Day, my heart is with you, and the Heart for Humanity, heart to heart. So thanks, all the best, Sangram. Thank you very much.
Thank you, sir. Thank you.
Manisha, I can't hear. I was able to hear Dr. PC Manoria, but last part I didn't hear anything. Are you connecting me or where? What is happening?
We are able to hear you.
Yeah, Dr. Hiremat, sir, we are able to hear you.
Your slides are also on.
Yeah. Yeah, kindly make it full screen, sir. Yeah. Slides are not moving.
No, I can't hear them. नहीं नहीं मैंने वॉल्यूम डबल चेक किया, म्यूट नहीं था मेरा। From where? But are they saying that I should give a start?
Yeah, we are able to hear, sir. You can start.
Can I start my talk?
Yeah. Volume little to be raised.
Can I start?
Yeah,
Yeah,
sure. Volume
I can't
to be
hear
raised.
you.
We are able to hear you. There is something from your end.
All right, so I can hear you now.
Yeah.
So
We
this
are
is
able to
good.
hear you.
So I can start, right?
Sure.
Okay. So we look at how things have changed in the management of coronary disease.
Kindly come to near to the mic, sir.
last
Mic.
year or so. This is acute infarct. Somebody traveled about 45 minutes from a nearby place, and we took the patient straight to cath lab. This is the treatment when we talk of acute infarct these days. So this was inferior MI. Window was about 30 minutes, and we found a blocked artery, and this was opened up with an emergency angioplasty, and a huge artery opened up well. If this artery had remained occluded for a length of time, say a few hours, a big infarct could have happened and a lot of heart muscle could have been damaged. It produces safety in face of acute infarct, and also it preserves the LV myocardium. This was another gentleman who was actually playing tennis with a friend of mine, and he had chest pain. My colleague was able to clearly think that this was cardiac pain, brought him quickly. And this was a 45-year-old gentleman with no risk factors at all. The window period between onset of chest pain and presentation to the hospital was 75 minutes. The ECG clearly showed acute changes in the anterior leads with some depressions in the inferior leads. So this was a very ideal case for a primary angioplasty. However, this was the Anant Chaturdashi day, the last day of the long Ganpati festival in Pune, and traffic is a big problem. So we calculated, and the lag time for the cath lab team to arrive was about 2 hours. So we thought it is better to lyse this patient. The window period was only 75 minutes. And we gave him TNK TPA manufactured in Pune. And the ECG improved tremendously. You can see within 3 hours, ST completely settled and a well-preserved R wave. The LV function on echo looked pretty good apart from mild hypokinesia. And this patient was taken up for angioplasty next morning. And we found critical disease in the LAD, but also disease in the proximal portion of the circumflex and a tight disease in the right coronary artery, which was dominant. So here is a case where LV is well preserved and you have lysed the patient. So every reason to go ahead with an angioplasty. So we did a LAD stent first, circumflex stent next, and next was the right coronary stent. So job was like a pharmacoinvasive approach, lyse first, and next morning an angioplasty, and that too a complete 3 vessel. So because patient was lysed, we could do LAD, circumflex, and right at one go. If we had taken him up at night, the previous night on a Sunday evening, we would probably end up doing LAD first and then get him back next morning or 1 or 2 days later for remaining vessels. So 2 procedures may be required if we are doing a primary angioplasty. So once you do a plasty, the antiplatelet therapy becomes crucially important. And here is a patient who had a brain tumor, and she underwent an angio as a part of fitness. It was going to be a long procedure, something like 8-hour brain surgery. And we found multiple blocks. So patient received 4 stents on the left side, and patient was discharged on a Sunday. I hate Sunday discharges for this reason, because many times we don't get an opportunity to check the discharge card. And Tricagilor was just introduced into the market. The patient was on Tricagilor for about 5 or 6 days in hospital and was doing well. On Sunday, the resident felt that we have forgotten to give patient clopidogrel. So she canceled Tricagilor and she wrote clopidogrel, and patient went home on single tablet of clopidogrel. As we all know, unless you load, the clopidogrel action is not on. And on the 4th day, she went home on Sunday. On 4th day, she came with cardiac arrest, and she was resuscitated and got to the cath lab, and we found both LAD and circumflex. A very big circulation was completely occluded, and we had to do angioplasty while on massage. Patient survived, but it was a heroic effort to get her out of this trouble. So we know that the Charisma study clearly indicated that clopidogrel aspirin is a better combination compared to aspirin alone. And the risk reduction was 23% if there is an MI with this combination compared to only aspirin. So all of us started using clopidogrel aspirin as a combination ahead of only aspirin. And this is the comparison between clopidogrel, prasugrel, and Tricagilor. And Tricagilor has some advantages, that it is the direct acting. This is receptor binding is not necessary, rapid in onset, and more than 80% inhibition can be achieved with prasugrel and Tricagilor. I think world over, we have seen that most of the acute cases, ACS or AMI, nobody is wanting to use clopidogrel, but we either use Tricagilor or prasugrel. Because Tricagilor has faster action, and PD offset is also slow. So important issue is there is no non-responders to these two compared to clopidogrel. There are luckily very few patients who have clopidogrel resistance, but those who have, I think we have all suffered because a perfectly done angioplasty, and yet you would get stent thrombosis because of clopidogrel resistance. between the two, how do you make a choice? I think many of us, and I've seen across the country, most of the cath labs and cardiologists, they seem to prefer ticagrelor ahead of prasugrel, though both have shown better effectiveness compared to clopidogrel, more or less to equal extent. So I think choice is a lot very individual. The patients who are unreliable, one must remember that prasugrel is an OD dose, while ticagrelor is a BD dose. So patient has to remember to take 2 tablets in a day. So this is actually a comparison of all 3 molecules put together. And if you have a really complex angioplasty, I would rather prefer using ticagrelor or prasugrel ahead of clopidogrel, just because some percentage of patients have clopidogrel resistance. And in case after doing a very dynamic angioplasty, if patient has clopidogrel resistance, you would have big problem. Ticagrelor has quick onset of action, and irrespective of treatment strategy, it could be PCI, it could be medical management, or it could be CABG soon, you can still use ticagrelor. So most of the acute cases are now done with ticagrelor across the world. This is actually a ESC and ACC AHA guideline for the duration of DAPT for ACS management. And if patient has no bleeding risk, I think the duration can be longer. It could be 12 months, and some of them can continue beyond 12 months. If there is a high bleeding risk, both ESC as well as the American guideline, they sort of tend to stop the DAPT at 6 months and continue only one of the antiplatelets beyond this time. Now, the bleeding risk is something which is pretty obvious to many of us when patient comes for follow-up after discharge, and it shows many patches where we can see subcutaneous collections. I don't think many or any one of us are doing sort of response tests to the DAPT therapy following a PCI. Now, this is the DAPT score. I think one must get accustomed to it. And if you are having a negative DAPT score, I think the possibility of bleeding is much high. So here you would probably make an exception and probably may not give aspirin and just use ticagrelor or prasugrel. While if you have a DAPT score which is on the positive side, 2 or more, I think you can safely give DAPT therapy for a longer duration. And this is what how the low DAPT score and high DAPT score. High DAPT score are the non-bleeders, and you can continue dual antiplatelet therapy for a long length of time aggressively. While those who have low DAPT score, I think you must ask yourself whether you need to give both or you can manage with single antiplatelet therapy. Some of these stents, especially Medtronic, have shown that single therapy also could be good enough with the quality of stent that we have these days. So the duration of DAPT therapy over last 20 years has significantly changed. In 2003 to 2006, it was a short DAPT. As time went, then came the longer DAPT going beyond 12 months. And then there was this discussion whether who to take long DAPT and who should take short DAPT. And today we have learned to individualize the approach. Many people, when the patient comes for first follow-up, they actually check the platelet inhibition and then decide who should go for longer DAPT. Longer DAPT will probably give you safety and the individual is appropriate candidate for long DAPT therapy. Now, Pegasus was a specific study where ticagrelor, two strengths, 90 twice and 60 twice, was compared with aspirin alone. And these were the risk factor: elder patient, diabetes, second prior MI, multivascular disease, and chronic non-end stage renal disease. So these were the candidates. And in this case, you can see compared to placebo, these people are receiving aspirin. The 60 as well as 90 were found to be more effective dose of ticagrelor. So it appears that ticagrelor alone can be used in patients who have high bleeding risk. Now, switching therapy also is important many times. Like patient has received a particular molecule, either prasugrel or ticagrelor. Now, these are effective, but when we say effective and more effective compared to clopidogrel, we are also buying a possibility of excess bleeding risk. So at some stage, one would like to change them to clopidogrel, and this is how you change. For ticagrelor, nothing great is required. You can give a full loading dose of clopidogrel after 24 hours of last ticagrelor dose. While on patient is on prasugrel and you want to switch to clopidogrel, you can just give 24 hours after last dose of prasugrel, you can give dose of clopidogrel. Now, this offset of action is important because so many times we would get requests from our surgical colleague as to patient is on dual antiplatelet therapy and when to stop because patient has got, say, a fracture or patient wants to undergo a prostate surgery. So in patients who are treated with CABG preoperatively with ticagrelor, 5 days of discontinuation was initially recommended. Ticagrelor, I would feel, probably has a quicker offset. So once you start last dose of maintenance, the action comes down in about less than 3 days. And it is probably the quickest. So how to stop before surgery? I think aspirin, you can stop 7 days later, 7 days before surgery. And also prasugrel needs to be stopped 7 days. Clopidogrel, 5 days is generally enough, while ticagrelor, 3 days is enough. So if you have a patient who is actually coming for non-heart problem and requires some kind of surgical procedure, I would choose ticagrelor because a short duration of off period, the action is off, quickly do whatever surgery and restart. The onset of action of ticagrelor, loading dose 2 tablet, 90 milligram, is almost immediate, and you would get a quick benefit of its quick antiplatelet activity. Now, this Twilight study was another important study, especially when you have a patient who has high bleeding risk. In this, there was one arm getting ticagrelor plus aspirin, while the other arm received only ticagrelor twice as we conventionally give. And there were a large number of patients, and they were followed up with for 15 months, and then subsequently standard of care. And it clearly shows that ticagrelor monotherapy was as effective as adapt ticagrelor therapy. The event rate were almost same. So ticagrelor monotherapy was non-inferior to ticagrelor DAPT for the composite endpoint. Also, ticagrelor monotherapy has fewer bleeding risks. So those patients where you are worried about a possible bleeding, like low birth weight, elderly, or super elderly patients, I think you can skip aspirin for after initial 1 month or initial 3 months, and could continue patients only on ticagrelor, and the bleeding clearly is much less with single therapy. So this actually summarizes the platelet therapy for high bleeding risk patients, and for those who are not at high bleeding risk, stable cases and acute cases. We all know that in acute cases, we like to take antiplatelet therapy for a longer length, and this is how the length is calculated for different group of patients. When you want to switch back to simpler clopidogrel, there is a thought process, and when you want to stop the newer antiplatelet agents, prasugrel or ticagrelor, you can stop and put them on clopidogrel. Bleeding risk, if it is high, sometimes we need to do this sooner. If you're doing it inside 6 months, I think you have to be careful, because the stent really need a good antiplatelet cover at that time. This is another case, unusual, but this is ectasias of the coronary. This was a youngish gentleman, and he was about 28, 29, and he came for an ACS, and when we did his angio, we could see the ectasia or aneurysms in the proximal portion of the LAD. You can see the diameter is 9.6, 8.3, 6, when the actual vessel is probably around 3 millimeters. So these ectasias, I think we should anticoagulate these patients. Earlier, we used to use warfarin. Even today, the current data is more with warfarin, aspirin combination, or warfarin clopidogrel combination, while the NOACs are probably getting tested for these kind of aneurysms. So the tailoring the antiplatelet therapy based on bleeding risk and ischemic risk is very important. So as you go away from the index event, index procedure, like angioplasty, here the need for antiplatelet therapy is very strong, but as you go away, the need probably drops down, and stents get covered, and you could switch them to single antiplatelet therapy. So when does this risk end, risk of stent thrombosis? I would probably feel that first 3 to 6 months are very important. After that, one could take a calculated risk and stop one of the antiplatelet therapy. So this is how the DAPT score helps. Low DAPT scores patients are most often harmed by longer DAPT duration, while high DAPT score are most often helped by longer duration. So this DAPT score is very important, and based on whether you are less than 2 or more than 2, you can make a choice whether to stretch your DAPT therapy for a longer duration. I think this is more or less same as what we said, less than 2, more than 2. And if more than 2, you can go for a longer duration. Now, the DAPT was effective for stent thrombosis as well as ischemic events unrelated to the stented area. This happens pretty often that you stent the most important lesion, and there are some 40–50% narrowings spread here and there. These are potential threats, and they could give somebody acute infarct, and these also need to be protected. So the DAPT therapy, if given for a longer time for stented patients, will take care of the non-obstructive lesions which are not stented during acute phase. So in complex PCI, tricagular monotherapy after initial 3 months of DAPT therapy was associated with significantly lower clinically relevant bleeding without increasing the risk of ischemic events. So all elderly patients who are, say, above 80 years, and we have used DAPT for initial 3 months, you can think of getting them to a monotherapy with tricagular subsequently. Also, the stent choice, if you're sort of worried that this patient may not tolerate long duration DAPT therapy, the stent choice also could be different. And the ultra thin stents are available. And also the Medtronic stent, the Onyx, has important data where they have stopped DAPT at the end of 1 month, and a single antiplatelet therapy was able to take the stent performance forward in a very effective way. This is again the very little difference with monotherapy and DAPT therapy. So this is a Korean data. So I would probably feel that we should, whenever we are worried about bleeding, we should consider giving monotherapy, and that it will work very well. So when you are thinking of these, I would probably feel that we need to use high pressure balloons like OPNNC is a balloon where we use pressures like 40 or 45. The important issue is in OPNNC, the balloon does not swell. So the possibility of vessel damage or vessel rupture is probably not there. As you can see here with other high pressure balloons, they tend to swell, though small, but there is a swelling or increase in diameter, which is not there in OPNNC because of its dual layer. Also, if you are worried about a bleeding possibility, always end up with OCT at the end of the procedure, and make sure that the stents are well opposed to the vessel wall. If you achieve like this, like in this case, this was a LED stent, and diagonal was a balloon. So this is a KISS. But LED stent is, though it is very long, something like 38, it is very well expanded. It's touching the vessel wall, and the possibility of thrombosis, even with a single antiplatelet therapy, would be very small, probably close to 0. So the imaging modalities in the cath lab are also very important, and you should always compare these with the CT in the radiology department. Also, the dual antiplatelet therapy can prevent sort of repeat events from happening from the culprit lesions and also the non-culprit lesions. So stented artery or stented segment, as well as non-culprit lesions which are left behind because they are not critical, will probably get the benefit of dual antiplatelet therapy. This was one case. This gentleman actually walked into my office and he was talking of some chest pain here and there, not very specific. However, his stress test was strong positive. And we told him to come for an angio, but he was thinking it's not really necessary. And he kept waiting. This is what happened during that waiting period. He had an inferior MI. He presented fortunately early. These were the streptokinase days, pain settled, ECG also settled. However, when we did an angio, the artery remained occluded. So we worked on this. The entire artery length was full of thrombus. So we aspirated whatever thrombus we could and gave intracoronary GP blockers and put him on anticoagulation. No stent was given because the entire artery had thrombus. This was actually a very well gymmer, and he used to train many people. And this was on day 5. There was a blocked artery. As I mentioned, we gave abciximab, no stent, aspiration of thrombus. And this is how we maintain the lipid chart. In our chart, date, the total cholesterol, triglyceride, the good cholesterol, the HDL, and the culprit cholesterol, the LDL, and then the treatment and whatever changes you make in the treatment. I think we should all learn to make a chart like this so that we know patient is responding to which kind of therapy. This patient exactly 10 years later, 1998 was the previous one. And this is 2008. He has come with another inferior wall infarction. So the question was whether we have an inferior wall coming from the same right coronary artery. I mean, there are ways in which you can pick up a circumflex infarct from a right coronary infarct. And typically, the right artery was exactly the same what it was in 1998, flowing well and no trouble. And the infarct came from circumflex artery with a critical lesion. Luckily, the artery was not blocked, it was flowing, but had a critical lesion. Incidentally, important thing to note is also the LAD is not filling up. So from 1998, in next 10 years, the LAD has got occluded. Patient has not realized it. It did not give an anterior wall MI. So it was probably a slow progression to an acute infarct and collaterals coming from these two vessels. So we stented this circumflex with good quality stent on day 2. And then we worked on the occluded LAD. You can see here, no flow in the LAD. So we had to use CTO techniques and we established a flow. Important to remember that this gentleman is only 48 years and he has irregularities all the way down the LAD. So if at all he needs surgery in future, the Lima graft will probably need endarterectomy to LAD. So this is how sometimes we get, the surgery was done 22 years back. The graft to LAD was working well. The graft to OM had occluded and a stent was placed here. So this is a combination of surgery and angioplasty. However, in this, beyond Lima junction, the LAD has shown diffuse disease. I don't think we have a short answer to this diffuse therapy as yet. Maybe drug balloon could be effective answer, but most of these patients are elderly, and probably even small dissections may not be very easy to handle. This was a post-surgery issue. Patient had a patient is a doctor. He's 84-year-old. At age 42, he had a surgery in Houston, and he had these 1, 2, 3, 4 grafts and a Lima. Yet he had an inferior wall infarction. So we treated him conservatively because for almost 30 plus years, the surgery has kept him good, and we wanted to know what is happening. So we gave conventional therapy, and we did a CT which showed a lesion in the graft to the right coronary artery. Then we took him up for an angio, and we could see a critical lesion in the right vein graft going to the right coronary artery. Whenever you have these, you're clearly worried about distal embolization, which could be troublesome. You could end up with a no flow, slow flow phenomenon. So we use this filter which catches all the debris, and you can see a lot of clot and muck caught here. However, when we take pictures after putting a stent, you can see a nice flow, and the original native vessels are also beautifully seen. So this is sort of help between surgery, bypass surgery, and cardiologist, giving a benefit to the patients. Now, this is a young Indian. He was actually a very, very fit person. He used to cycle long distances and sort of used to keep his weight, cholesterol, everything under control. And so when he talked of some degree of chest pain, we thought it was probably not cardiac. He was about 38, 39-year-old, but his stress test came positive, and we did an angiogram which showed lesions in the left main going towards LAD. Then the circumflex, which was a dominant circulation, also had a critical disease. So there are multiple bifurcations in this case, and we chose the simplest way to address the bifurcation. As you can see, his ventricle is bright, and we had no difficulty putting one stent going down towards the last branch. This side branch was treated as provisional. We didn't put a stent. Then we put another stent from circumflex mouth towards the OM1, keeping left main to LAD stent in position that time. And then we did a final kiss at all the junctions. And it's more than 4 to 5 years. This patient comes, does a regular annual stress test, and is doing well. Of course, we had to work hard on his LDL, and we have brought it down to about consistently between 25 and 30. So we always like to use a big dose of rosuvastatin for these kind of young individuals who have very high LDL. So this is how we ended up. You can see the disease in the proximal LAD, ostial LAD in the left main, and the circumflex entire length is disease. And this is after putting these kind of stents, we have established a flow. So your technique has to be good. You have to spend all your effort thinking what is going to be best for your young patient in long term. And then you say the best prayers and go ahead and do your case. So there was a time when the Syntax one PCI data, when compared to surgery, you can see here 17 point odd and 10 point odd in bypass surgery. There was a big difference. However, with newer technique and advancement as to which lesion needs to be done. The gap between the angioplasty and surgery, this is syntax 2, where revascularization strategy for MV disease was used with a full knowledge of FFR and intravascular imaging. The gap has narrowed down. So the FFR is another technique. Many of you must be aware. And in this case, the LAD was the culprit vessel, but there was a lesion in the circumflex, which had 3 important distal branches and also an important right coronary artery, which was also dominant. So we did an FFR, and to our surprise, the lesion in the circumflex did not have important FFR. So 0.89 did not need angioplasty, but this one was 0.67. So we put a stent here and we did LAD, of course, which had a very critical 0.45 FFR. So this is a new technique where you measure the pressure. This is a lesion, so you measure pressure beyond and proximal to the artery, and thus you can get a ratio. And if the ratio is less than 0.75, that vessel needs stenting. So this is how this lesion was left behind, and only LAD and right coronary were stented. This is another case. We were unsure whether this LAD needs any help. However, the patient had a previous stress test, which was grossly abnormal, and LAD was the only artery showing some kind of disease. So we did an FFR, and you can see the FFR is less than 0.75. So we ended up putting a stent, a long stent in the LAD, and thus clearing doubt whether LAD needs a stent or it doesn't need a stent. So this is actually the imaging from inside the OCT, and the optical coherence tomography can actually show you a lesion like this. It can show you a crack in these lesions, and thus many times in acute cases, it helps us, like a good thrombolysis, no significant lesion. Many times we leave the lesion alone and put them only on anti-cholesterol tablets and anticoagulation. However, if there is an ulceration like this, this probably needs stent, and that is how you can prevent repeat happenings. So this is a gentleman who had infarct about 10 or 11 years back, inferior wall infarction. And he actually came because he was going to take a retirement whenever it is due, around 60 years. And he said, I want to get a full check. So stress test was grossly abnormal. LV was well preserved. So despite an inferior infarction, LV was well preserved, probably getting a lot of collateral supplies from the left side. So he has put 10 years, and the lesion thus is a chronic occlusion, and we had to use different techniques. We generally use a long sheet, then you use downsize the balloon. Here we have this NIC Nano Hydro, which also comes at 0.85 diameter, and a micro catheter. So all these come to your help when you're dealing with such a difficult case. And you can see at the end of the procedure, it turns out to be a huge, important right coronary circulation. Agreed that 10 years he has lived with it, but he has lived on collaterals. And the anticoagulation is another very important consideration in cardiology. And whenever you have low to intermediate Hasbled score, you can give a triple therapy, and you can continue dual therapy after 6 months, and this could be continued indefinitely. If the bleeding risk is high, triple therapy can be curtailed to just 1 month, and then you can switch to dual therapy. So all these are happening with different studies coming in. You have this dabigatran 150 twice, dabigatran 110 twice, and warfarin comparison in this redual PCI. And dabigatran worked much better than warfarin in both the strengths. So the recommendation for stroke prevention in atrial fibrillation thus can be anticoagulation, and NOAC probably simpler and safer compared to warfarin. And this comparison of these three, the Capri, which actually gave clopidogrel its important, Pegasus and Compass. And we have learned in Compass, a small dose was quite effective in prevention of repeat events. The survival in coronary artery disease also depends on the LV function. And if your LV function is preserved, you can see the difference between this and when LV function is depressed to less than 50%. So always do everything that helps you prevent the LV damage. Now, this is how spot testing is done. And spot testing is probably done in many places around age 60 or 65. And we do a stress test most of the time. If it is good, we say everything is good, pat on the back, take good care, and so on. These days, the coronary CT has emerged, and coronary CT gives a lot of information compared to any other tests. So these are actually, the RCA shows signature high-risk napkin ring lesions, which are vulnerable. So even if this lesion is not critical, the infarct can happen because it's a vulnerable plaque. And here, to change the lipid core, we would probably use a big dose statin to get to stabilize the plaque and also probably expect regression. So the CT angio can actually help us decide whether the plaque is low intensity or high intensity, and both can get different kind of therapy for graft prevention. This was a bypass surgery case. This portion, after 7 years, portion of the Y graft is blocked here from Lima junction to OM1, and subsequently from OM to PDA. So this area is not getting enough blood supply, except that this portion of the graft is patent. So we decided we will stent this portion, left main to OM. This will open a flow going to the OM1 and through the functioning Lima to OM2, and then open the CTO in the right coronary artery. I think we managed to do that, and patient did very well. Is doing pretty well for last 7-8 years. So CT angio has now emerged as a gatekeeper to the cath lab. Many times we do CT and the plan is ready in our mind as to where is the lesion and what kind of therapy we need to offer. And thus we can do SOS consideration. The CT angio also shows what is called as a signature high-risk napkin ring vulnerable plaque, which you can see here. And the lesion may appear non-critical on the conventional angiogram. But since CT was done, we knew that this is a vulnerable plaque and was thus stented. So treadmill test and CT angio both give you very important information. So I wouldn't ridicule treadmill just because CT is available, because it gives you a lot of radiation and also significant amount of contrast when you're doing this. Also, it cannot be done when heart rate is fast. So both have their good points and bad points. However, CT angio can tell you which plaque is vulnerable. As we discussed earlier, some plaques may not be critical, but they are vulnerable and would probably need stenting. This was a case, we did 5 stents and she moved from age 89, she moved from age 84 to 89. And at age 89, she used to work in the field. I mean, I'm not somebody who would put an 89-year-old on treadmill, but when we discussed with her, she said, yes, I'm ready to walk on the treadmill. And here she's walking with a perfectly normal CT angio as a follow-up and also a negative stress test. So CT calcium score is very important. Many of these calcium scores are ignored, saying that calcium scores do not necessarily mean a lumen obstruction. However, things are changing and we are probably thinking of giving more importance to these calcium scores too. The atherosclerotic plaque predicts better than clinical findings and stenosis. So CT angio can tell you what kind of plaque you're dealing with, a vulnerable plaque or a stable plaque, and thus help you decide how we can make the patient safe. So here is actually a comparison between one vessel disease and 3 vessel disease, and how long they can go, 5 years survival with medical therapy. And clearly 1 vessel can go much, much longer. However, we must also remember 3 vessel cannot go long. So this is something where you would probably not argue that the patient needs something. It could be angioplasty, it could be a bypass surgery and so on. So whenever a patient needs a kind of a heart evaluation, we start with ECG, probably do a stress test. If this is not conclusive, we may do a stress thallium. CT angio is a big help and I use it very often, especially for high-flying executives who are probably cannot reach hospital if they get into trouble during one of their travels. And lastly, of course, the gold standard conventional angiogram. So the atherosclerosis, if you have a positive test, you could be somewhere here, moderate to very high risk. And if you're negative, you are low risk, however, need to take good care. So whenever around 60, you think of choice of tests based on clinical likelihood, patient characteristics, and a preference, and of course the availability. The coronary CT today, to me, becomes a very important test because it not only shows that there are related ST depressions on treadmill, but also helps you to teach the patient that here is a block, and if he doesn't take good care, he's going to come into trouble. And in this study, the ischemia study 2019, the winners were optimal medical therapy, a big time winner compared to angioplasty and surgery, and of course the CT angiography, again a big time winner. So give it its due, the coronaries can be very well visualized on CT. Also, we are talking of an LV function based on the CT images. And now the technique is getting modified that if you have a lesion in one of these vessels, and if you feel you need to know whether that lesion is important. You can even do a non-invasive FFR or IFR to decide if patient needs a procedure. In India, we get young individuals. There's many times they're less than 40, sometimes even 30, and they have multivessel disease. So the young Indians, they carry a high risk compared to Westerners. And that's why we need to be very aggressive in our thought process as to how to prevent heart diseases. This is actually the ESC investigational approach for a stable chest pain. Nothing very different from what you and I practice in our clinical study. And this is where I think we are moving into a percutaneous aortic valve, the tower. This was an 88-year-old gentleman. We actually fixed his 2 vessels with stents, and then this aortic valve replacement is also done percutaneously. This is ready to get discharged on the 3rd morning. Very happy that he did not undergo a cut on his sternum. So I think we'll stop here. We tried to go through what are the important happenings in coronary disease in last little time, and I'm sure we could discuss any issues which are important. Hi, Dr.
Thank you.
Srinaram.
Thank you, Dr. Hirmat, for a very mesmerizing and illustrative talk on coronary artery disease. Dr. Nagraj, you are there?
Yeah, he's there, sir.
Dr. Nagraj,
Yeah,
the
yeah.
most distressing situation in coronary artery disease in the current scenario is increasing number of young infarcts. We see young celebrities dying. They are maybe 30 to 40 years, sometimes even less than 30. So what is responsible for these young infarcts in India, and how they differ from the elderly infarct, and what can be done to minimize this?
It has been observed that, in India, the susceptibility comes out of our ethnicity, which cannot be changed, obviously. And of course, the associated risk factor that one sees that has been shown in Interheart study also, the history of conventional risk factors, in fact, especially of smoking, the stress, the diet and exercise factors. These are some of the things which, and the premature onset of diabetes and high blood pressure, all these seem to contribute. In other words, these are all, mind you, modifiable risk factors. In other words, if a young man comes into my office, I would like to go over these risk factors and try and see in category in which he can be advised regarding modification of these risk factors. Suffice to say that the prevalence of these risk factors are on rise in our younger Indians, and it looks like it is contributing. It looks like it is more a plaque rupture or a plaque erosion with, rather a thrombotic element being there on ACS, and a couple of patients that Dr. Hirmat showed, which was wonderful lecture, Dr. Shirish. In fact, thrombotic element being more, one should be offering stent as a kind of option so easily. In other words, one should be careful, because after all, if it is required, if it can be avoided, it should be. If it is not possible to avoid, we should go ahead and stent the patient with the modern stenting with obvious technologies which you have nowadays. I think I have taken enough time to answer this question. I hope you are satisfied, Dr. Manoria.
Dr. Vivek Jolly, you have been a member of MCI. You're also a prominent social figure besides an excellent surgeon. But we know politicians die of heart attack, bureaucrats die of heart attack, member of medical fraternity die of heart attack, celebrities die of heart attack. But despite all this, why prevention of CAD in our country is in a very low profile?
What was the last sentence?
Why prevention of coronary artery disease in our country is on a low profile?
True. No, it's not only coronary artery prevention, for everything, even doing a health insurance, we always wake up late. But World Heart Day is exactly for that. And it's not a big thing to prevent, because disciplining your diet, doing some simple workout, not smoking, these are not very big demand.
Yes.
And
Your audio is not.
history child later on. So I think, can you hear me?
Yes, yes.
Can you hear me?
Yes.
Audible or not? Hello? Okay, excellent.
Yes.
So what I'm saying is that prevention is very simple. The food, the workout, the not smoking is nothing great. And if somebody has a family history, prevention has to begin in the childhood. Parents, and not, this is not late. But this only awareness, that's all. There are some factors which are now emerging, like pollution, which are beyond us. That the government, politicians will have to come in. But these simple 3-4 things is only awareness at the parental level, putting the seed at the childhood.
Dr. Hiremat, what about a diabetic infarct? Is the management different compared to a non-diabetic infarct? And for diabetic infarct, what are your strategies?
Well, the initial therapy, when somebody gets a chest pain, and whether he needs a primary angioplasty, straight to cath lab. I think if patient is late beyond 2 hours and 3 hours, I would take them to cath lab, because even if you cannot revascularize him completely, I think opening up the occluded vessel will save a lot of heart muscle. And that is the best way to salvage the heart muscle. Whatever you do later, of course, can be based on the angio, how many vessels are diseased, how easily you can handle them with angioplasty. Or, of course, Dr. Jowhari can do a bypass surgery.
Dr. Nagaraj, the concept of antiplatelet de-escalation has come into vogue. Dr. Hiremat talked about. So there are two antiplatelet de-escalation strategies. Either you switch from aspirin plus ticagrelor to ticagrelor alone, as was shown in the TOLAI trial in the TICO, or you have aspirin plus ticagrelor oblique prasugrel and switch to aspirin plus clopidogrel, a weaker DAPT. So which one you prefer?
It all depends upon the patient characteristics and what kind of reasons why the patient required a dual antiplatelet therapies. Now, there are some issues like, multiple stents, patient with diabetes and diffuse disease and bifurcation lesions and longer length the stents have been used and the stent lengths themselves that have been deployed in a particular patient. All these factors, we take into consideration when we would consider, de-escalation of dual antiplatelet therapy. In case I have to continue antiplatelet therapy in a dual fashion, definitely I would like to continue the same unless the bleeding risks are higher, as was pointed out by Dr. Girish. Also, I would like to comment here that I would like to continue at least for about 12 months of dual antiplatelet therapy if it is possible, and if it is not possible, at least 6 months and 3 months, and 1 month also has been tried. In other words, we err on continuing dual antiplatelet therapy, especially in those patients who are on higher risk scales. And in case I have to change over, I may even change over to continuing ticagrelor and removing the aspirin, as it has been shown in the TOLAI trial. And it is a good trial to fall back upon to consider ticagrelor as a single antiplatelet therapy to continue. Thank you so much.
Is prasugrel an unsung hero compared to ticagrelor? Both are very good antiplatelets, but we see prasugrel not used to that extent.
I don't know in the sense, possibly the initial trials of prasugrel showing the higher bleeding risks and also ticagrelor showing good efficacies all have played their roles, and prasugrel group people awoke little later. Maybe it is something to do with the trials which were not kind of conducted at an appropriate time, which resulted in the lagging behind of usage of prasugrel, at least according to me. I don't know what Shirish thinks about it.
Dr. Himat, is prasugrel an unsung hero? What is your viewpoint?
You could say that, but I would probably feel the offset action is clearly longer. I mean, there is a clear disadvantage that suppose somebody has bled somewhere and you want to stop prasugrel, it will act for almost 7 days. While ticagrelor will be off in about 3 days or around that. So I would probably feel this is a big advantage in using ticagrelor. The downside, of course, is it is required 2 times a day, and 2 times a day for long length, some years. I think it's people forget also. So probably ticagrelor is clearly very popular. How is it in your lab? Most of them are on ticagrelor, or they are on...
I go with the ticagrelor. I hardly have used the prasugrel as a kind of a chronic therapy, and my experience has been so limited with prasugrel at this moment, at least. Also, there is a question in the chat box, Dr. Manoria,
Chat box.
about CTA versus coronary angiogram.
In head-to-head comparison of CT angio to conventional CG, what are the pros and cons?
As Sirish talked so much about CT angiogram, let him start off with, as he already has answered that question.
Yes.
Actually, I was very slow in sort of accepting the importance of CT angio. But as time has gone, I think it clearly tells you a lot more. I mean, it's only thing, the quantum of contrast. I think most of the CT cases, they inject 80 cc of contrast, while the conventional angio we can finish in about 30 cc. So somebody who has had some kidney issue, then elderly patients, I would probably prefer a conventional angiogram.
Dr. Jolly, what is the current status of minimally invasive CABG in your center?
Both minimally invasive surgery, bypass surgery, and robotic assisted bypass surgery, which I'm now doing very routinely, are there. And there are more than 100 surgeons in India who are now doing minimally invasive bypass surgery. But the problem, because of too much of private sector, the overhype is creating a problem. So which are the patients for whom you should do a minimally invasive bypass surgery? Those who require a graft at the LAD diagonal, maybe the upper OM. These are the patients in whom I will do a minimally invasive bypass surgery. More lateral, back, the posterior grafts, there is quite a possibility that we may give good, not give good quality graft, give poor quality graft. And a large number of these patients I have seen coming back for problems very early. And there are many patients who come as early as in 6 months. So about 25–30% of the angios that come to me can be good enough for minimally invasive bypass surgery. The robotic assistance, the importance is it's completely painless, because when we do bilateral IMA through robotic, then, and I'll do a Y, the Y can be on the platform of the octopus, and you really do not spread or do anything. So chest wall hurt is least, and these patients fast track a lot. But more impressive thing about robotic is the vision is so grand and the panorama is so theatrical that surgery becomes very, very simple and easy. And also in a minimally surgery, surgeon's body is very uncomfortable. But when you're doing robotic, you are sitting aramse on a chair, and the surgeon is also, his back is hurt the least. So that is a great advance. And what is happening about our country, now there are 148 hospitals in our country which have got Da Vinci robots. And the urologists, oncologists, GI surgeons, and gynecologists are doing quite a lot of surgery. So I'm very sure that beyond 8 or 9 of us, in another 2 years, almost all the centers you will see robotic cardiac surgery, because all these centers have brilliant cardiac surgical teams. So this will be very interesting. And one important advance that has happened here, especially the valve surgeries, that where do you put the incision? If that is little wrong, then the surgery can be quite difficult. Now with the hologram, you feed your CT scans, everything to the hologram, create a hologram. And with the Microsoft HoloLens, that will become very common by next year. If you put the HoloLens for some time, you can exactly see the entire anatomy in front of you. You can correctly mark your incision or your points of the robotic arms points, and then take out the HoloLens. And then you will be extremely on the dot and on the point. So things are going to change massively in next 18 to 24 months.
Dr. Hiramat, you are there? Dr. Hiramat? Okay. He perhaps has left. Dr. Nagaraj,
Yeah.
what is this concept of dual pathway inhibitor, and what are the subset of patients you would like to put on a DPI? That is aspirin plus rivaroxaban 2.5 milligram twice a day.
Yeah, in fact, the COMPASS trial showed this particular concept that, atherosclerosis is driven by not only just platelets, but also the thrombotic element there. And having these dual pathway being inhibited, atherosclerosis is likely to be kind of kept under control, or even the events will be reduced. That's what exactly happened in the COMPASS trial. About something like 5,000 and odd patients were compared in the randomized controlled trial. This was kind of exciting for Dr. Braunwald also to write an editorial in NEJM as to, kind of the thrombotic era in cardiac practice is emerging. Having said that, rivaroxaban, which has been tried, is typically used in a low dose like 2.5 milligram. And of course, the patients will have to be followed up. As you mentioned in your introductory remarks, polysuicide, polyvasculitis are the patients are generally the targets for such therapies, which has been shown to be useful. In other words, it has not caught up still the fancy of a cardiologist or a physician, simply because of the perceived concern about the bleeding risk. I don't know how many of your patients get this dual pathway inhibition in your routine practice versus the post-PCI follow-up patients.
In our experience, the result in peripheral arterial disease has been dramatic. We had patient who was crying for pain day and night, ready for amputation. We put them on this regime, and after 2 or 3 months, the pain gradually disappeared. So we have seen very dramatic response to this. The risk of bleeding, I think, is not that much with this low dose, but somehow, as you rightly said, highly underutilized. The physicians are not yet aware of this concept. The other thing in the COMPASS trial was that cardiovascular death significantly reduced, stroke reduced dramatically, 42%, but MI was only a numerical decrease. So people say aspirin, was it an appropriate combination with rivaroxaban, or could it have been better if you put a clopidogrel plus rivaroxaban? There's no trial at the moment, but what is your personal viewpoint on this?
Yeah, it could be tried, I guess, it could be considered in an intuitive manner, because clopidogrel is a little better anti-platelet than aspirin. Aspirin, while works with about just 20 to 30%, 40% is the inhibition with clopidogrel. So one can consider that in case you feel that aspirin is not doing your job.
Dr. Jowli, sometimes we have patients whose angiogram is done, they have 3-vessel disease, they are candidates suitable for a bypass surgery, but they continue to have ischemic pain. So will you like to operate these patients on a single or double antiplatelet agent, or you like to operate off the antiplatelet agents? What is your preference?
I will always prefer to put them off. And if you can put them on heparin, that is still better. But clopidogrel, the non-aspirin drugs, can be quite a problem. And if you get a problems of blood transfusion, TRALI post-operatively, it can be very debilitating and very expensive.
Dr. Nagraj, what is the current status of BVS, biodegradable vascular scaffold? Initially, they were withdrawn. So what is now the current status? They were bouncing back, or what is the status?
Bouncing back is a kind of an overstatement. I'll be optimistically cautious that I would like to see more data, more clinical reviews and consensus. And I hope I have no personal experience with biodegradable scaffolds. I would like to request Dr. Shirish to talk about it in case he has any personal experience about
I
it.
think Dr. Shrees has left, I think. Dr. Hirmat, I think, has left.
Yeah, okay. In case you
So Dr. Jolly, what are the problems with the redo CABG compared to the first CABG?
Redo has actually, sir, come down to ground now. There is absolutely in our hands no difference in complications between redo and a fresh case. Even if there is a old IMA there, left internal memory, then also I think people have become even the junior most person has become very sleek. So today both valves and bypass surgery. So the problem risk factor mainly is the ventricular muscle. And all these technical problems are now become very straightforward.
Dr. Nagraj, a 35-year-old patient develops MI. His younger brother asks, what is my risk of developing MI in future? So what would be your reply to him? Because he's worried his MI is
very important, important for this particular day, that we should be looking for the risk factors profile the patient has, or the person has, the family history. Obviously, is a premature coronary artery disease in the elder brother. You should definitely take a look at the genetic risk that the patient may have. Although I would not like to do the genetic testing as such at this moment, but I would like to take a look at the patient's lipid profile particularly, and also all the reversible risk factors. Of the lipid profile, I'd like to take a look at the LP(a), honestly. And in addition to that, I would like to take a look at the risk enhancers, including the additional the family screening of such these patients. And as was pointed by Dr. Shirish, I would like to take a look at the calcium score, if it is possible in this particular patient. I would like to go on to add, even if the lipid profile is borderline, I would like to go ahead and take a look at the patient's calcium score, because I'm little worried about this particular patient's risk at this moment, especially if he has some risk factors like lipid abnormalities, or a pre-diabetes, or history of smoking, obesity, and high BMI, etc. Of course, the smoking and the smoking and the sedentary habits also should be taken care of.
Dr. Sanam, should we finish, or what is your?
Yes, sir. We will wind up. We'll have one
Is
key
there any
takeaway
questions from the audience, or you can?
There's one audience question, as I could see that. Based on the findings of CT angio, do you take a decision to intervene? Decision to intervene means what? Intervention doesn't mean angioplasty or surgery. Intervention means even the medical management or medical counseling. If the patient has a calcium score of more than 0, it means the patient has a minimal coronary artery disease. If it is more than 100, definitely more than 100 calcium score, the risks happen to be higher. And of course, the coronary atherosclerotic plaque, which can be examined by the CT coronary angiogram, will be able to tell us about the risks involved in this particular patient. I would like to go by the patient's symptomatology, if it is possible, and if it is positive for especially perfusion scan, if it is significantly positive coronary angiographic score, then that will be definitely helpful. Before I embark upon interventional, rather invasive coronary angiogram, I would like to have the total evaluation of this particular patient and subject. In case I do an invasive coronary angiogram, it is more for defining the coronary artery anatomy and also offer the procedure if it is required. Of course, one should be careful if the patient is totally asymptomatic non-invasive functional testing is completely negative in such of these patients. That's how I would approach in this particular patient.
Yeah, what is the take on aspirin, sir, for primary prevention now? Where is aspirin placed now?
Aspirin should never be used as a routine, like a regular patient of asthma or high blood pressure, or a regular patient of diabetes, for instance, and a regular, middle-aged person of 40 to 50, just because the person happens to be overweight or stressed or anything like that. It was a fanciful prescription just about something like few years ago. Now, with so many varieties of trials, including the high-risk patients and the low-risk patients and the older patients trials showing negative results for the usage of aspirin, I'll be hesitant to introduce aspirin myself. And I strongly advocate not use aspirin in case somebody else has prescribed it. Thank you, sir.
Not for primary prevention in vast majority of patients,
Yes,
only for secondary prevention.
that's right.
So before we conclude, sir, we will have one take-home message. Dr. Javadi, sir, from your side, for the audience, what is your key takeaway for today's? I think he has a connectivity issue. Dr. Manohar, sir, your
I think coronary artery disease in Indian occurs a decade earlier. Diabetes occurs a decade earlier. The mortality is high. In Indian coronary artery disease, one sets in, runs a malignant progression, very high morbidity and mortality, increased revascularization rates, increased restenosis rates, increased morbidity and mortality. So great emphasis should be made on prevention, prevention, and prevention. Otherwise, the number of CAD will go on increasing, the morbidity and mortality would go on increasing. Strict preventive measures must be employed at a very young age, maybe up 30 or maybe less, in patients who have a family history of coronary artery disease.
Yeah, Dr. Javadi, sir, your comment, your key takeaways.
My three takeaways are that I think we should be very strict about our guidelines. In Indian patients, in-test scores are generally high. Nobody does in-test scoring. The patients requiring bypass surgeries are actually far more than we imagine. And I think CT coronary is being overhyped. We should be very careful about that. Formal coronary angiogram is still being underplayed. Patient will spend a lot of money. Get a lot of radiation and still come out. So I forget about basics.
Yeah,
I have seen patients in reputed institutions.
I think we lost connectivity.
Yeah.
Because
Yeah,
it's traveling.
Yeah, traveling.
Yeah.
Yeah, Dr. Nagaraj, this is your comment, your key takeaways.
This particular session, excited me simply because Dr. Shirish was able to bring out all the facets of the evolution of the management of coronary artery disease in its glory or kind of fire. And what we could see is, tectonic shift of concepts, development of techniques and technologies, and of course, the development of drugs and their usage, and development of devices and their uses, and indeed the development of clinical trials, and thereby, exciting the writers of the clinical guidelines to be issuing the guidelines almost every other year from either Europe or from Americas, suggesting that, we should be on our toes to learn new concepts and try and understand and appreciate the new concepts to make sure our patients do benefit. But at the ground level, the prevention is the key, as has been pointed out by AHA for a long time now, that, we should take care of our, society's good health in terms of modifiable risk factors, starting at the age. As the children enter the primary school, in my opinion, as the children enter the secondary high school rather, as the children enter into the pre-university or join their degree courses, or how many times MR Medical College students get their review done at the time of admission and as they are leaving, how their risk factors change. You can produce good data as to how people pick up the risk factors as they are leaving medical institutions where the prevention is taught as much effectively as anywhere else in the world. In other words, the prevention is the key, as Dr. Vivek was mentioning. And indeed, I do not agree totally with him that there is some kind of difficulty in usage of technologies like CT coronary angiogram. A selective usage will definitely be helpful, and I'm sure the prevention that is emanated from the societies like API and also the medical college teaching will help the society at large. Thank you so much.
Yeah, Dr. Vivek, anything you want to say?
No, that's it.
Yeah, thank you. So before we conclude, I thank Dr. Manoria sir for his excellent moderation and sparing your valuable time. I request Dr. Vishwanath, Secretary, to convey or propose a vote of thanks. Dr. Vishwanath.
Thank you, sir. Good evening, all the delegates and respected Chairman API, Dr. Govind Babu, and all the seniors. First of all, I express my thanks to the Chief Guest, Dr. Alka Deshpande, Madam, and Dr. P.S. Shankar and Dr. Brothanathan. It was very nice of Dr. P.S. Shankar to start the whole program by reading out the chapter on Dr. Alka Deshpande. It was a very nice gesture. Thank you, sir. And of course, my immense heartful thanks to our distinguished speaker, Dr. Hiremat sir. It was a very comprehensive lecture. You started with basic concepts, then the multiple trials, de-escalation of dual antiplatelets, and probably with multiple cases that your experience, also you shared your experience. That was very good. I thank you, sir, once again, sir. Same time, I thank all the experts, Dr. Manoria, sir. It was a very excellent moderation. You made the discuss with two experts, Dr. Nagaraj Desai, sir, and Dr. Vivek Javadi, sir. And we all know them. And as sir said, through API, we keep following you, sir. It was sharing your experience with us probably helps us a lot. Thank you once again. At the same time, my immense thanks to Dr. Biradar sir, who keeps organizing such events. Now we know how difficult is it to bring out such eminent speakers in one platform, but he does it again and again. My special thanks to him. Also, my thanks to Dr. Rajshekar sir, past chairman, who has joined and as usual, very active. Thank you, and all the delegates who have joined this webinar. Thank you once again.
Thank you, sir. Thank you.
Thank
Good
you.
night. Thank you.
Thank you so much. Good night.
Thank you.
Bye-bye.